Hi, I'm Chris Sutton, and I'm going to be doing my obesity video number 2. I'm going to start with my machine check. I'm going to check my pipeline pressure, make sure that it's at least 50 psi and greater, and that there's no crossover with my pipes. I'm also going to check my E-tank, make sure it's at least halfway full and the key is available. And it looks like it is halfway full. I'm going to make sure I have my ambu bag. I want to make sure I have my suction and hook that up and make sure that's working appropriately. I'm also going to look at my rescue meds, make sure I have my apples available. I want to make sure I have my extra airway equipment, and I'm going to check my flow meters and my Link 25 and make sure they're working appropriately. I'm also going to get my bulb out, my suction bulb out, and perform a low pressure check. And I'm going to check my flow meters and my vaporizers and make sure there's no leaks there. And I'm also going to make sure that my vaporizers are full enough for this case. I'm going to go ahead and make sure I have AC power. And I'm going to calibrate my O2 sensor and make sure my CO2 absorber is not desiccated or exhausted. I'm going to make sure my monitors, my ventilator settings are at the appropriate settings, especially for this case and this patient. I'm going to check my ventilator valves, my inspiratory and inspiratory valves. And I'm going to go ahead and do my high pressure check. Okay, I'm going to switch it from ventilator mode to manual mode and turn my APL valve, close my APL valve all the way and push my O2 flush until I have about 30 centimeters H2O and make sure that holds for at least 10 seconds. And that looks good enough to me. Okay, now we're going to go ahead and move on to my patient here. We're going to do a preoperative assessment. I have my patient John Doe. He's a 42-year-old male. He has a BMI of 44. His height is 190 centimeters and he weighs 160 kilograms. He is coming to the OR for an ablation to treat atrial fibrillation. He has a history of AFib, obesity, OSA, hypertension, hyperlipidemia, diabetes, and he also did have an appendectomy done. His current medication is based off of his chart. He takes Eliquis, amiodarone, metformin, atorvastatin, and sildenafil. And so based off of what the surgeon said, he wants to continue with Eliquis, amiodarone throughout the surgery and hold everything else. Based off of the labs that were sent, he did have some CBC, CMPs that were sent that did show that they were within normal limits. And we also sent a type and screen just in case. We did do a chest x-ray for imaging that showed that he does have an enlarged heart. The surgeon wants to continue with the procedure. I went ahead and asked him some questions. Okay, John, I'm just going to ask you a couple questions right now. Do you have any medical problems, such as in your lungs, heart, stomach problems? John, have you had any previous surgeries? Have you had any problems with anesthesia in the past? Or has your family had any issues with anesthesia in the past? Have you or your family members had anything called malignant hyperthermia? Do you have any allergies? What medications do you take apart from what's already reported in your chart? What did you have for breakfast this morning? And John, I'm just going to ask you just some physical questions. Are you able to walk up 2 flights of stairs or walk 2 blocks without feeling winded? After asking these medical questions, I'm going to go on and do a physical assessment. I'm going to check his airway, have him open his mouth, found that he has a Mallampati score class 3. I also found that he has a thyromental distance less than 7 centimeters or less than 3 fingers. We did do an upper lip bite test, and he has a class 2, an incisor distance of 2 fingers and no more than that. He also has a neck length or girth that's very large around the neck, and also found that his neck range of motion is limited because of the excess tissue around his neck. I did auscultate his lungs and his heart, and I did find that they were within normal limits. So based off of his previous history and also his current condition, I have determined that he has an ASA score of 3. So John, the plan for today, I've determined that you are a difficult airway, and so we are gonna intubate you awake, and we're gonna do some upper airway blocks using something that's called a fiber optic scope. If that doesn't work out, We're gonna do, our plan B is gonna do a glide scope or a fast track. And if that doesn't work, then we're just gonna postpone this surgery. So the benefits of this procedure, doing using a fiber optic. So I'm just going to discuss some of the benefits, risks, and alternatives. So the benefits of a fiber optic is it allows precise navigation around some challenging anatomics in your airway. It also gives me direct visualization of your airway structures, and it might make this procedure a little bit easier. However, some of the risks, there could be some trauma to the vocal cords, to your trachea, to your larynx. Hypoxia could happen. There could be some airway obstruction. However, there are some alternatives. We could do a glide scope, or we could do a fast track, postpone the case, or an emergency situation, we could do something that's called a cricothyrotomy. Okay, so after informing my patient, John, I have obtained consent for this procedure from him. Okay, so now we're in the OR room. We just want to make sure we have our equipment all ready to go. We have a large bariatric bed for John, and then we have our emergency airway equipment. We have some bath blankets for ramping, just to put him in that optimal position. We're going to place an art line. We have an art line kit. We're going to do a number 3 Mac. We have a number 3 Mac blade, as well as a 2 miller. We're going to place 2 18 gauge IVs. We have 3 different ET tube sizes, 7, 7.5, and 8, but we're going to use the largest one, 8. And then we're going to use our fiber optic scope. So we'll use blankets again for ramping, just to kind of put him in that optimal position to align his airway accesses. So we're going to place his art line. And now that it's been placed, we've set it up, and it shows that it has an optimally damped waveforms. And we're going to place our monitors, 12 lead EKG, as well as a pulse ox. And now we're going to position our patient. We're going to put him in like a sniff position. We want the sternum to line with his chin, using the ramp technique with the blankets. So I'm going to go ahead and put him in the ramp position. Oops. All right, okay, looks like he's in a good position. Okay, we're just gonna leave in this position just for a little bit, okay? So now, John, we're gonna go ahead and do our upper airway blocks. So first, we're gonna do our glossopharyngeal nerve block. We're gonna go ahead and insert the needle at the base of the palatoglossal arch, anterior to the tonsillar pillar. And if we aspirate air, that means we're too deep. If we aspirate blood, that means we need to go more medially. So after correcting our position, and we're in the right position, we're going to go ahead and inject on one side 2 mils of 2% lidocaine, and repeat on the other side. Okay, now we're going to go ahead and do our superior laryngeal nerve block. So we're going to find the hyoid bone, and then we're going to inject at the inferior border of the greater cornu of the hyoid bone. We're going to inject 2% lidocaine, about 1 mil, outside the thyrohyoid membrane, and then we're going to go deeper, deep to the thyrohyoid membrane, and inject 2 mils. And then we're going to repeat on the other side. Okay, now we're going to go ahead and do the transtracheal nerve block. We're going to identify the cricothyroid membrane. We're going to puncture that, and then we're going to advance the needle in a caudal direction. So this will reduce, doing it caudally, it's going to reduce the likelihood of vocal cord injury. We're going to aspirate for bubbles, but before injecting, we're going to inject about 4 mils, 2% lidocaine. We want the patient to take a deep breath. So during inspiration, we're going to inject those 4 mils to the tracheal lumen. And then as soon as the patient, we want to hurry and pull it out before the patient starts coughing. So the patient will cough, spraying that local anesthetic upwards through the cords. Okay, now we're going to pre-oxygenate our patient with 100% O2 for 3 to 5 minutes, and ensure there's a good seal. Okay, now that we've done that, we're going to go ahead with inserting our 8 ET tube using the fiber optic scope. Okay, here we go, John. We're going to go ahead and insert this. You might feel some pressure. just past the vocal cords. You can see the carina. And I'm going to advance my ET tube. Over my fiber optic. Sometimes it can be a little bit tricky. All right. Looks like we're past the vocal cords. Go ahead and pull out. There we go. All right. We go ahead and connect into the ventilator. And I'm gonna check my my end-tidal CO2 waveform, make sure there is waveform, and I'm also going to assess for bilateral chest rising and fall, as well as auscultate for bilateral breath sounds. Okay, and I'm gonna, using the size 8 at the teeth, it's about 23, it's at 23. I'm gonna go ahead and tape it so it stays in place. And now I'm going to use my induction medication. I'm going to give the patient, John, 150 mics of fentanyl, and then I'm going to give 200 milligrams of propofol. All right, so ensuring that he's asleep, I'm going to check his reflexes. Looks like he's asleep. I'm going to go ahead and tape his eyes shut, and I'll go ahead and remove the blankets. All right, and then I'm going to titrate my sevoflurane to 1.8%, and I'm going to titrate that as needed during the procedure. Okay, now that the case is done, I'm going to go ahead and start waking up my patient, turn off my Sevo. I want to ensure that my patient, again, right at the end of the case, I'm going to ensure that my patient is able to lift his head for about 5 seconds, follow commands, has adequate respiratory mechanics such as spontaneous breathing, and we're going to do an awake extubation since this patient is considered a difficult airway. And the reason behind this is to assure that he's able to protect his airway as he wakes up. Okay, John. All right, John, I'm going to go ahead and take out that ET tube, okay? I'm going to go ahead and suction you, okay? As I pull it out, I want you to give me a good cough, good cough. There we go, good cough. I'm just going to suction, make sure I get all those secretions out. And then I'm going to just start them on maybe about 4 liters of oxygen from there. Okay, now I'm going to bring him to the PACU and give report to the PACU nurse. So this is John Doe, a 42-year-old with no known allergies who has a medical history of AFib, obesity, hypertension, hyperlipidemia, diabetes, and appendectomy. Surgeon did an ablation to treat AFib. He has 2 bilateral 18-gauge IVs. He was stable intraoperatively. He has minimal blood loss. He had minimal blood loss. He received 500 mils of LR preoperatively, was also given 4 milligrams of Zofran 30 minutes before the end of the case, and 15 milligrams of Toradol postoperatively. And in the OR, his last vital signs showed a blood pressure of 135/90, heart rate of 85. Pulse ox showed 99% on 4 liters nasal cannula with a temperature of 36.5. Orders have been placed for CPAP, IV fluids, PRN pain meds, early mobility, and routine post-op monitoring. What questions do you have? Thank you.